Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 37th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Staying Hip, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on either the IBJI or the NSYMCA websites. Staying hip gets harder as we get older, not just because we lose track of the current trends in society, but also because functionality of the hip joint can be negatively impacted by injuries such as fractures, impingements, bursitis, and strains, and also by diseases such as arthritis, osteoporosis, and more. The hip joints are the second largest joints in the body, the largest being the knees, and have a wide range of motion thanks to their ball and socket construction. Hips are durable and bear our body weight as we walk, run, jump, and even when we stand. However, despite their durability, a disease or injury to our hip or hips can cause pain and mobility challenges, affecting our ability to bear weight and get around. Dr. Ritesh Shah is here tonight to help us learn more about the symptoms, causes, and treatment of hip pain. Ritesh Shah, MD, is a board-certified orthopedic surgeon with fellowship training in joint preservation, joint resurfacing, and joint reconstruction. He specializes in the treatment of both hip and knee disorders and offers advanced treatments, including minimally invasive muscle-sparing total hip replacements, hip resurfacing, hip arthroscopy for labrum repairs, minimally invasive customized total knee replacements, partial knee replacements, and knee arthroscopy. In addition, he performs revision hip and knee replacements. Dr. Shah loves what he does and really believes in precision medicine, providing personalized care to his patients using the most current, evidence-based guidelines, scientific treatment, and technology that is grounded in science, but at the same time innovative enough to continue to move medicine forward. Dr. Shah enjoys treating active athletic patients and helping them return to their high level of activity using novel, cutting-edge surgical techniques. A strong believer in evidence-based medicine, Dr. Shah makes certain that everything he does for a patient is validated by the most current clinical outcomes data available. He has written numerous orthopedic research articles and book chapters and has published surgical and video techniques for technologically advanced preservation and reconstruction procedures. During Dr. Shah's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the questions section on your screen, and I will receive them and relay them to Dr. Shah immediately following his presentation tonight. I do ask that you please keep your questions general, as Dr. Shah will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Shah via one of the options that will be listed on the slide shown during the Q&A portion at the end of his presentation tonight. One last thing before I turn the podium over to Dr. Shah. I invite you to mark your calendar for our next IBJI and NSYMCA Education Series program. On Wednesday, March 22nd at 7 p.m., Dr. Kevin Hayek will host acute and chronic knee pain. Thank you again for joining us tonight, and thank you, Dr. Ritesh Shah, for your time and your effort in putting together this program to help us stay hip and learn more about the symptoms, causes, and treatment of hip pain. Dr. Shah, please take it from here.
Thank you, Karen.
You bet.
Well, everybody, thank you for joining us today. I'm going to share this screen and share a little bit about myself. So today's topic is staying hip, and I want to focus on kind of 3 or 4 main diagnoses that patients oftentimes come in with when they're coming in to see me. Some disclosures. I've written this book, Pocket Orthopedic Surgery, that does have some royalties that come with that. I've invented a patient selection algorithm for total joint replacements. And then I do have some research support and speaker fees. My background, I am a Chicago born and raised kid, pretty much. I went to Loyola for undergrad, went to the University of Chicago for medical school, went to Northwestern for orthopedic surgery residency, and then went to WashU to spend as a fellow specifically focus on hip treatments, including hip arthroscopy, which I'll talk about in a few minutes, and then hip replacement surgeries, particularly minimally invasive type surgery. A lot of my background you'll find on these two websites listed below as well. My practice is exclusively focused on just hip and knee treatment, so I don't really see any other joint pain really. A lot of times we do deal with patients who have hip pain along with spine pathology, and some of that overlap is there, but exclusively hip and knee issues. And as you heard from Karen, you know, my treatments are non-operative, so hip injections and knee injections, arthroscopic treatment for both joints, hip resurfacing, which is a very unique procedure, and then outpatient hip and knee replacements, which I'll talk about. So what does a typical young patient come in with when they're coming in with hip pain? So most of the time when we think about hip pain originating from the hip, usually a patient will come in with insidious onset of groin pain. The picture that you see on the bottom there shows kind of a typical presentation of somebody saying, you know, my hip hurts. So you can see it's more towards the groin. And about 70 to 80% of patients will have pain in their groin when they're talking about hip pain. It's much less common for pain that's in their buttock to actually be hip pain. Only about 20% of patients that have buttock pain have pain that's actually originating from the hip. So that's an important piece of information to know as you sort of think about pain that you or your friends or family may be experiencing. Oftentimes, a younger patient will come in with pain where they may have pain with sitting or transitioning from a sitting to a standing position. So common typical problems they'll kind of come in with is say, you know, actually sitting at a desk work hurts. Achiness, soreness to that anterior groin. They may say that they have pain with long car rides, pain with airplane trips. And again, that's sitting for a period of time or sitting to standing transition can be a problem. This is typically how a younger patient, somebody that may be in their late teenage years, 20s, 30s, and early 40s may present. Oftentimes they'll complain of dull, aching type pain that kind of comes with this. And then this picture that you see on the bottom right, we call that the C sign. So the patient will kind of cup their hip going from the front towards the side, saying that's kind of where their pain is. So we talked about anterior pain that's in the groin, that's about 70 to 80%. Then we talked about pain in the buttock, that's about 20%. But about 60% of patients also complain of what we call lateral pain. That's pain directly on the side of the hip, kind of where our bony prominence is. Usually when we think about hip pain issues, they'll have deep anterior groin pain. Again, I'll usually ask about transition, so sitting to standing. Then we talk about putting on socks, putting on shoes, getting out of a car. If you're going into a bathtub, lifting your leg and going into a bathtub. What we call the log roll, so that's sleeping covers when you turn from side to side in bed. And then the C sign and the between finger sign. So common sort of questions that we'll ask patients about. As things progress, patients will talk about the fact that they have pain with weight-bearing activities. So standing in one position for a period of time, or walking for a period of time and then experiencing pain. They'll talk about pain with hip flexion, sitting to standing movements we talked about. If they're racket sport players, so things like tennis, paddle, pickleball, they'll talk about pain as they pivot, and they can get achiness and soreness with either that movement or movement laterally, side to side at the baseline if they're hitting. A lot of golfers would come in complaining of pain when they swing. Again, that pivoting motion can give them pain. We have runners that complain about pain with running, martial artists that complain of pain as they sort of pivot and hit a heavy bag. As things progress, sometimes patients will talk about associated mechanical symptoms. So in addition to pain, achiness, and soreness, they'll complain of things like catching or clicking or worse, locking. And patients will talk about how a hip can seize on them or hip can buckle on them, all as causes from originating from the hip. On physical examination, there's a whole host of things that I do for physical examination. But typically, this patient who comes in with hip pain will have pain when I do this movement to them. So that's when the patient is lying down flat on a table, and I'm taking their hip, I'm bending their hip to about 90 degrees, and then I'm bringing their knee over the midline of their body, and I'm rotating that foot outwards. And typically when a patient has pain with that kind of movement, we think about things that might be irritating their hip. So labrum tears, which I'll show you, cartilage flaps, arthritis, impingement, dysplasia are all common things we might think about. Some other additional tests that we sort of look at are the one at the bottom here, is to look to see if the hip flexor, the iliopsoas, is irritated. So that is resisted extension, and the patient is trying to flex their hip up. We'll do a figure 4 test. It's a picture at the top there to see if the hip is irritated. And then we can do what's called an apprehension test. That's a bottom right picture there, where we're rotating the leg outwards to see if the patient is having pain. These are both videos that we commonly see in patients that might have things like snapping hips. And these patients typically will state things like, oh, I think my hip is coming out of its socket, or I think I'm dislocating my hip. And it's not that the hip is actually dislocating, but it's that the muscle is actually snapping side to side. Now, what's interesting about this is if you have a snapping hip, or if a friend or family has a snapping hip, commonly these snapping hips are not problematic. They don't cause pain. Commonly, they do not need any treatments other than a good stretching exercise. They don't cause harm to the muscle. They also don't cause any harm to the joint. So the physical examination also includes a few specific things. So number one, inspection. And usually I'll watch a patient walk up and down the hallway as they're coming in to see me, or sometimes when they're coming out of imaging. There's palpation. So we look to see if there's soreness on the outer border of the hip on that lateral side, so kind of that side of the hip. See if there's any tenderness of palpation when we sort of look at the front of the hip. Is there any soreness as I'm pressing over the muscles in that area? We look at range of motion, as I explained earlier, and particularly stiffness. Whenever the hip is irritated, whether it's due to soft tissue injuries like muscles or ligament or cartilage damage, or if it's due to osteoarthritis, where we might have wearing down of the joint itself, there's usually reduction in range of motion, meaning there's usually some stiffness present. And first, stiffness starts with internal rotation. That's where you were to take the foot and you rotate it internal. And that can give patients pain and be stiff. As things progress, then you start losing range of motion with flexion, with extension, and with the other rotation, external rotation. I also do an examination for strength. And then we do the specialized testing, which is listed here. I won't go through all of these because that can take a lot of time. But needless to say, a whole host of specialized hip testing is performed to see if there are specific irritants for this patient, for a patient's hip. When we think about impingement, and this is a very common pathology we see in younger patients, particularly younger active patients. We think about impingement as when the ball and the socket pinch, and I'll show you a video in just a couple of minutes of what that is. But there are specific areas that can be problematic. So we divide the hip up, particularly the socket of the ball and socket joint of the hip, and we look at it like the face of a clock, the picture that you see below. And commonly the problematic impingement areas that can cause a tear to the labrum are between the 12 o'clock and the 3 o'clock position. So that's the front of the hip towards the front of the body, kind of deep in the groin, and towards the top of the hip, the superior side of the hip. There's a whole host of other areas that can impinge. So I get asked often, what is impingement? So here's a good video of what impingement is. So you can see here the ball and socket joint is coming up, and the ball abuts the edge of the socket, kind of where the labrum is. And that cartilage structure there at the edge, that triangle that's red there, is the labrum. With repeated movement, the labrum will continue to bend, and subsequently can tear. As the labrum tears, you can also develop cartilage damage, i.e. early arthritis. One of the big reasons that patients have pain when they're younger is because the labrum is torn and because they have impingement. The picture at the top shows why. So on the CAM type impingement, that's one type of impingement, and FAI is an acronym for femoroacetabular impingement. The ball of the ball and socket joint is misshapen, and it has that bump at the ball and socket joint there, which then pinches over and over again, causing injury. The other type of impingement is more on the socket side of the ball and socket joint. So this video shows here, the socket can form in a way where it covers the ball more than it should. And as that hip flexes up into a seated posture, the labrum once again can tear and give patients pain. Think about the labrum like the gasket to the hip joint. And when that tears, it can give patients a lot of pain. We get a complete x-ray workup. I won't go into this in detail other than the fact to know that there's a lot of measurements that are made to ascertain femoroacetabular impingement along with other hip pathologies. Many patients, when we get concerned about them having impingement and symptoms that are consistent with impingement, we usually obtain an MRI arthrogram. So oftentimes patients will ask, what's the difference between an MRI and an MRI arthrogram? So an MRI is without any injection into the hip joint. An MRI arthrogram is where inside the hip joint, the radiologist will inject contrast, so dye. And that water-soluble dye is injected so that we can then follow the labrum. Here in the picture on the right, you see the stripe here, that's the labrum that is torn. The MRI arthrogram also helps us find whether there is any significant osteoarthritis or other pathologies present, like avascular necrosis, which is loss of blood supply to the ball of the ball and socket joint. In many patients who have hip labrum tears, the most common treatment that we provide is actually not surgery. The most common treatment we provide is a good course of physical therapy, combined with deep tissue massage work, combined with some good stretching and strengthening exercises. For many patients, that can suffice. For patients who are very active, who have symptomatic or painful hip labrum tears, unfortunately, many of those have to get fixed. Now, the good news is that when we do fix them, we fix them using arthroscopic techniques. So here's a cartoon about hip arthroscopic surgery. So usually 2 or 3 small incisions, about 5 millimeters in length, are used to then insert a camera and instruments to then fix the labrum and correct the impingement. Here's a video of what it looks like. So here's the labrum. You can see the gasket to the hip joint here, and it's torn. And I can push it down with my probe. I can lift it up with my probe. And that should not be able to do that. It should be fixed fairly snugly to the edge of the socket there. The rest of the cartilage, which is this whole area on the inside the socket here, is nice and white and pristine. There's no major cartilage damage. So this is what the inside of a hip looks like with hip arthroscopic surgery. I think it's a very cool procedure. I think it helps patients a lot. What this one study allowed us to have as a consensus statement is that for a patient to qualify for hip arthroscopic surgery, we want to make sure that the patient has hip pain, may have mechanical symptoms like clicking, catching, or stiffness. That's one. Number 2 is we want to make sure that on physical examination, that when I examine that patient, they have signs that are consistent with this. Then number 3, we want imaging to be consistent. If all 3 things are consistent, then that patient would benefit from hip arthroscopic surgery. This is a picture of what the same thing would look like. So on the left here is a picture of the labrum that is torn, and the right is a labrum that is fixed back to the edge of the socket with stitches. On the bottom left is that impingement, that bony growth over the edge of the ball and socket joint. And then on the bottom right there is where we've corrected that. And these patients, again, have a lengthy recovery, but after the recovery they do very well. Here is an X-ray of the patient before and after surgery. Again, we've recreated that curve on the edge of the ball and socket joint. And these patients undergo physical therapy. So after the surgery is about an hour and 10 minutes. They're in the operating room for about 2 hours. Surgery involves a couple of small incisions. During the surgery, we fix the labrum, correct the impingement, clean up any major cartilage damage. That's pretty much always an outpatient surgery. The patient goes home the same day. The recovery isn't painful, but the recovery is long. So recovery involves physical therapy for about 2.5 months post-operatively. And it's broken down into 4 phases. So there's a protection phase with mobility, there's a controlled stability phase, there's strengthening, and there's return to sport. And the majority of patients that we're doing this surgery for are athletic people who are actually athletes in college, high school, or beyond, or they are athletes in terms of their recreational activities that they perform. So here's a nice story. If you ever wanted to read this or see this, WGN did a nice story on this flamenco dancer who had bilateral hip labrum tears. And after the surgery and the recovery, she was able to return back to dance. It was a very fulfilling thing for her. It was great for me as far as treating her and getting to see her kind of get back to herself again. And this is a little bit of an older patient who loved marathons and loved ultrathons. And he wrote a nice story about his process with hip arthroscopic surgery, having both of his hips fixed with labrum tears that were repaired arthroscopically by me, and then undergoing the recovery, and then subsequently getting first place at this Utah Valley Marathon, which is literally, if you've ever seen it, it's no joke. It's hilly, uphill. It's really a tremendous accomplishment. And again, fun for me to treat and get to see this patient go back to what he likes. So that is hip arthroscopic surgery. That surgery and that procedure and treatment is for patients who don't have any significant arthritis in their hip. Now, moving on to patients who have some arthritis in their hip. Now, this is where this is much more common, right? So if you look at arthritis, and these numbers have all actually grown. This is a little bit of an older slide. So the most common form of arthritis is osteoarthritis. And osteoarthritis is a wear and tear disease affecting almost 80% of people over the age of 65. That's a lot of Americans. We know a couple things. For the hip, the people that are affected by osteoarthritis are getting younger. We know that it's most commonly found in the hips, knees, and hands. I'll speak about the hips today. I also treat a lot of patients for knee osteoarthritis. There's a lot of contributing factors, and the cause used to be unknown. Interestingly, the single biggest cause of hip osteoarthritis is what we just spoke about, which is hip labrum tears. So when patients have hip labrum tears and the gasket to that hip, that ball and socket joint, is lost, that's when cartilage damage happens. And so for a lot of these patients who are younger, who have hip labrum tears that are symptomatic, we fix the labrum tear. Many of those patients will go on and enjoy their life and potentially never develop osteoarthritis. This is a good schematic of what hip osteoarthritis looks like. So if you look at the healthy hip on the left, you see a nice, pristine femoral head, or the ball of the ball and socket joint. There's no fracture to the area. The bone quality looks good. The cartilage looks nice and clear. If you look at the middle diagram, you can see that it's cobblestone. That cartilage is really kind of fractured down. It's worn away. And then X-ray, this is what we would see with advanced osteoarthritis, is that you can see there's no space between the ball and the socket. And if you look closely at the X-ray, the ball has moved up, meaning the leg has likely grown a little shorter because the cartilage is worn away. So in a younger patient who has bad arthritis to their hip, we have a couple of options. So this was about a 42-year-old male fireman that came in to see me for left hip pain. And when you look at X-rays of the hip, majority of the time, like this image, the left hip is actually the hip that's on the right on your image, okay? So that hip has advanced osteoarthritis. couple of things that we notice is, again, as we talked about with cam impingement, this patient has cam impingement. So the ball of the ball and socket joint, that ball has been misshapen. This patient probably had a labrum tear for a really long time. When he came in to see me, he'd already had an MRI arthrogram done. And the MRI arthrogram showed a labrum tear, impingement, and advanced osteoarthritis. Because the patient had advanced osteoarthritis, I could not perform a hip arthroscopic surgery for him, but rather he would need reconstructive surgery. So we'll talk about what we did for him. Initially, we started with non-operative treatment. We did cortisone injections into the hip joint. We did physical therapy, deep tissue work, worked on weight loss, holistic treatment, things like turmeric, glucosamine, to see if these would help. Eventually, nothing helped, and he needed surgery. So as I look at this patient is very young. He has very good bone stock. He's in a very active occupation. He's a fireman, and he has to return to full duty. There's no option for light duty. We know that he has advanced osteoarthritis of his hip, and he has cam impingement with a labrum tear. So the two options for this patient, again, hip arthroscopy is not an option. Can't scope his hip. But for the two options for him would include a hip resurfacing or a total hip replacement. So when you think about activities, okay, and the way that we grade activities is kind of the chart on the left. And this helps define whether it would be more beneficial to undergo a hip resurfacing or a hip replacement. So in patients who are very active, okay, so I'm looking at number 9 and number 10 in this scoring system. So sometimes they participate in impact sports, or they regularly participate in impact sports such as jogging, tennis, skiing, acrobatics, ballet, heavy labor, or backpacking. And by regularly, we mean at least once a week or more. I usually like to think about it a couple days a week, okay? So if patients are really at that higher level of activity, then they would benefit from a hip resurfacing more than a hip replacement. So here's the good and the bad of a hip resurfacing. First of all, the schematic on the bottom shows you what a hip resurfacing is. So hip resurfacing is basically a metal cap that's put on the ball after the ball is made round, and then a metal shell that's implanted into the socket of the ball and socket joint. There's no long stem like you would have in a hip replacement. It has really good results in patients who are 55 years or younger, usually males, just because of the way their anatomy is, with good bone stock. It has great results for return to work to even very high levels of activity, such as occupations and recreational activities as described. It has no limitations in activities after the surgery down the road. Usually about 6 months post-op, the bone strength goes back to normal. And the longevity is really good. It can last 15 to 20 years. We cannot use hip resurfacings on patients who have metal allergies, cannot use hip resurfacings, generally speaking, in patients who are of the female gender, mainly because of the anatomy. And technically, it's a much more difficult surgery. So hip resurfacing is one of those surgeries where less surgeons are doing these surgeries, just because it's technically demanding. And this is that same fireman that we had. I performed a left hip resurfacing on him. Again, you can see that metal cap with that short post and the shell that's inside. If we look at a very famous tennis player who recently underwent a hip resurfacing, this is Andy Murray. And I don't know if any of you watched the Australian Open, but if you did, you may have seen that 5-hour match he was involved in. I've watched him play live. He's an amazing athlete. He's super motivated, but he had a hip resurfacing and he's rebounded back from that in a really great way. And personally, I was happy to see this guy come back. So here is a X-ray of a hip resurfacing on the right. So the cap with the shell, and a total hip replacement on the left. So the shell, the ball, and stem. So it's important as a patient, as you sort of, if you need these surgeries, to ask all the right questions so that you can do your research and you can choose the most appropriate procedure for you wisely. We know that with the bears, They had an opportunity to choose wisely. Unfortunately, that didn't happen. So now to move on to the hip replacement surgery, which is one of the most successful and cost-effective surgeries of all time, and actually one of the most cost-effective interventions in medicine. It ranks behind carpal tunnel surgery and cataract surgery as number 1 and number 2. There are about 350,000 total hip replacements done annually in the US, so it's a little higher than this number. We know that the incidence of this surgery has gone up, meaning there's more of these surgeries performed now compared to just 20 years ago. And we know that they're lasting much longer than they really ever have, because the implants, the bearing surfaces, the technology has all improved. In addition to that, surgeons are able to use much better technology to make sure that the components are placed in an excellent way. Furthermore, it is now truthfully better than ever and faster recovery than ever. Personally, I started same-day outpatient hip replacement surgery a decade ago. So I have a very long track record and history and experience in this, and I have the opportunity, luckily, to speak a lot on this topic, as well as teach a lot of surgeons from different places, both inside the US as well as outside the US, on how to perform these same-day hip replacement surgeries. It's remarkable now what patients are able to do and how quickly they recover. I'll show you some videos in a few minutes. With our experience, I would tell you the number one and most important thing when we think about outpatient total hip replacement is that you cannot, as a surgeon, sacrifice outcome. Quality is the best, the outcome's got to be the best. I personally, for me, feel that same-day surgery is the best option for patients. It has higher patient satisfaction, it has lower complications, it has better team and surgeon satisfaction as well as patient satisfaction. We know that when we're doing outpatient total hip replacements, we can do these at the surgery centers as well as the hospitals, depending on a few different factors. Patient health, patient function, patient situation at home, sort of the home care, along with what makes sense in terms of what's best for the patient in terms of going to the hospital setting or the surgery center setting. Interestingly, in both settings, this can be done as a same-day procedure, and we've been doing it now for over a decade. I've been very happy with it. It is important that, in my opinion, as we teach surgeons how to do this down the road, that newer surgeons that are adopting same-day surgery make sure they take time to feel comfortable with it, build safe and appropriate pathways for patients, and establish an excellent team. I've been lucky to be doing this for a while, and we have these things down. If you look at sort of the most important things for same-day total hip replacements, or what I call rapid recovery, it starts with selecting patients that are going to be good for this. So usually patients who are functionally a little bit better in terms of being able to walk, in terms of their health, in terms of their help at home. Every patient undergoes a preoperative consultation, undergoes a preoperative medical clearance. Then there's a lot of homework that's done by the surgeon as well as my team. So there's a lot of preoperative planning and templating done. So recent x-rays are utilized to size implants, size the structure, plan our resections, plan sort of what the hip is going to look like before we ever set foot in the operating room. We also then order all the things we need to make sure everything's going to be there. And we also order all the things we might need. So in the event that we need something, we're not left stranded. All of those things are brought to the hospital. So a tremendous amount of planning is done regularly. There's preoperative physical therapy. I strongly believe in prehab. I think you'll see a slide in a minute that really shows the importance of this. And then home setup is important. If you're undergoing a same-day procedure, you want to make sure that tripping hazards, slipping hazards, your pets, all those things are kind of in a way that is safe for you to come home so that you don't slip, trip, fall, and hurt yourself. Surgery, minimally invasive surgery. I'm a big believer in minimally invasive surgery, soft tissue preserving surgery. I like certain technologies, and we have very dedicated, appropriate anesthesia and pain pathways to have patients do well with this. Prehab is critical. I think there's so many important things that you gain as a patient from going to prehab. You get less pain, less anxiety, more confidence. We also learn how to climb stairs and use assistive devices before you ever undergo a hip replacement. It's really critical. Plus, it reduces your need to call the healthcare provider. We know that nowadays, with healthcare being larger and bigger, sometimes it's difficult to get a hold of the people you want right off the bat. This reduces that need for you as well. So this picture may gross some of you out, so I apologize for that in advance. But if you look at minimally invasive hip replacement surgery, it's a small incision surgery. This is about a 3-inch incision that the entire total hip replacements can be done through. It's not just one particular technique. It's not just one pathway. It's not just education. It's all of this together. And it takes time to evolve this. And luckily, again, we've been doing this way for about a decade with plenty of experience to have done this for a while. I strongly believe in technology. So almost all my hip replacement patients, I use this technology. This is a little camera and a little sensor that's utilized during the surgery. And what it allows me to do is it allows me to know in very precise terms what the positioning of the implants is going to be while I'm operating, as well as leg lengths, which is critical for patients, offset and hip center, some of the other biomechanics that we care about when we do the surgery. Now, what I love about this, utilizing this technology compared to some of the others out there, is that all of the hardware is all disposable. So I don't have to worry about infection risk or sterility issues, which is really important. Additionally, it only adds, on average, 3 minutes to my surgeries. So we're not adding a whole host of time for patients to be under anesthesia and have a wound that's open. And it gives me all of the information I need to do a surgery really well, that's reconstructed well, without having to irradiate or use X-rays in the operating room to a patient's pelvis, which I tend to worry about. I don't want to put radiation to a patient's pelvis more often than it needs to be there. So in the operating room, we don't need to use X-ray, which is really fantastic. Important things as far as this goes, and these are both videos, by the way, of patients who are. The patient on the left is literally 45 minutes after his hip replacement. The patient on the right is 2 weeks after her hip replacement. So we use injections around the hip. I do not use a catheter, so there's no need for a bladder catheter. We avoid IV medications. We hydrate these patients. It's a nice narcotic minimized way of doing this. The patients are not lightheaded, they're not dizzy. The last time we transfused a patient blood was, I don't even know how long ago, but that does not happen very often nowadays, which is great because we have great ways to maintain hemostasis. And then a nice occlusive dressing is placed afterwards. Patients don't have precautions afterwards. The majority of patients can bend, stoop, turn, all within a level of comfort. This is a patient that's about 20 days after her surgery, and you can see that she can bend, stoop, turn without any major issues. And we've shown this, as well as the Mayo Clinic has shown this. There's been some nice attraction to this from different news outlets. So Fox News did a nice look at a patient, I want to say maybe 5 years ago, and he was a patient from Japan that had a hip replacement surgery done, and then the next day he walked 10,000 steps, and the following day he walked 15,000 steps and moved on with really minimal narcotic utilization post-op. And then the Chicago Tribune did a nice story on one of my patients who was a guitarist in a band, and 2 weeks after surgery performed live and loved it. It was very gratifying for us. If you go to the website, you also have an opportunity to see some videos of active patients doing active things. I love taking care of active patients, high demand patients. I call these patients just because for many of these patients, it's much more than walking around the block. And this is not to say that we want to minimize how important walking around the block is. It's very important. But as we look at patients who want to get back to playing tennis or racquetball or pickleball or paddle, who want to play golf, who want to play half-court basketball, who want to water ski, who want to snow ski, it's exciting to take care of those patients and return them to all those things in life down the road, where they don't have to stop themselves from living life again and enjoying it, which is the whole point of why we do what we do. So for patients, I tell them expectations are you're going to walk and hike, elliptical machine, bicycling, skiing, golfing, light tennis, swimming, and then usual timelines for return to work. Well, I tell you, most of these are a little bit sooner than those numbers say. Here's the average time that a patient spends after their outpatient hip replacement surgery at a surgery center. So, and at the moment, I believe it's as fast as anywhere in the world, if not faster than most places. So when a patient undergoes surgery, generally speaking, about 45 minutes after surgery to within an hour of surgery, that patient is walking. After that, around 70 to 80 minutes after surgery, that patient climbs stairs. And right around 2 hours after surgery, the patient is going home. And it's just an amazing, exciting thing to watch these patients get back to all the things they enjoy. Very gratifying for all of us to take care of these patients. So I'll stop with that, and we can pause for any questions you might have.
Awesome. Thank you, Dr. Shah. That is really exciting. And things have changed so much in the past few decades with regard to hip replacements. And it's really exciting to me. So thank you. Okay. So Ed asked, does having both hips replaced make one more susceptible to hip bursitis and IT band strains?
So Ed, it's not the hip replacement itself that's making you more prone to bursitis. Interestingly enough, a good percentage of patients who have bursitis, they have not only hip issues, but many of them can actually have some low back issues as well. And so usually the hip and the back combined together can lead to persistent bursitis. Most of the time, if a patient has bursitis and they come in to see us, we commonly treat that with a simple injection or some deep tissue work with a physical therapist or a trainer, and that usually takes care of most of their pain.
Great, thank you. Laura had asked, what treatment do you recommend for labral tears? But you covered that so completely. I don't think we need to go into that. So thank you for covering it. She was one of our first people with a question right at the beginning. So I thought, oh, yes, you hit it. So thank you. Carrie asks, can you permanently damage the hip flexor?
Yes, there are occasional patients that we see who will have an iliopsoas tear. And I just recently had somebody who had an issue where I think they were pushing their car out of a snowbank and slipped, and they tore that flexor. So yes, that can happen, although it's quite rare. The majority of the time when patients have iliopsoas or hip flexor issues, there's a bursitis, there's inflammation to the area, and again, solved most oftenly with some deep tissue massage work.
Great, thank you. Can groin pain from the hip radiate to the inner aspect of the thigh?
Absolutely, yeah. So 20% of patients who have hip pain will have radiating pain down their thigh. And some patients who come in will only have isolated knee pain and not even complain about their hip. And then when we examine their hip will have restriction in range of motion, or will have pain with some of those movements I described. And when we get an x-ray, and I remember this 60-year-old patient who actually had knee pain, had seen another surgeon, underwent knee surgery, and did not improve. And then I saw him as an opinion afterwards, and I examined his hip. And his hip, we ended up getting x-rays at bone-on-bone arthritis. We did his hip replacement, and no kidding, the next day, his knee pain disappeared. Most of the time, knee pain doesn't disappear that quickly. Most of the time, knee pain will disappear like a few weeks after the hip replacement surgery.
Oh, wow. Fascinating. Thank you. All right. Can an x-ray be inaccurate in identifying osteoarthritis of the hip? And is it more accurate to have an MRI with contrast?
Yeah, it's a good question. It's not that the x-ray is inaccurate. It's that sometimes if you look at arthritis, most people think of arthritis as progression as being linear, okay? And I like to think about arthritis progression as being kind of more like this. So it's on a curve. So you might be here, and if you're on the lower end of the curve and you get an x-ray, the x-ray hasn't caught up to how much cartilage where you have. So a patient like this who gets an MRI, that might show more wear than what the x-ray shows. On the other hand, if you're here, most of the time the x-ray is going to show us enough because your arthritis is advanced enough to warrant that.
Got it. Okay, thank you. That's very helpful. Are the symptoms of hip bursitis different from the symptoms of hip osteoarthritis?
Yes, they are. So hip bursitis, you can get bursitis in a variety of areas in your hip, right? So you can get bursitis to the trochanter, that's on the outer side of the hip. You can get bursitis to the hip flexor, that's more towards the front of the hip. You can get bursitis to the ischial bursa, that's more towards the buttock. So any one of those three areas can have bursitis and can be termed hip bursitis.
Got it. Okay.
Hip osteoarthritis Hip osteoarthritis usually results in pain majority of the time to the groin, and then some level of stiffness with range of motion.
Got it. Okay, thank you. That's helpful to understand. All right. Do you prefer anterior or posterior hip replacement surgery?
Yeah, this is a question that probably I answer 10 times a day on my clinic days. Okay, so very common question. So I'll sort of just give you a short sort of spiel on that. So hip replacement surgery can be done via 5 different approaches. And unfortunately, the way that the media sort of presented this is kind of presented a yin and yang or a good or bad sort of look at this, right? And say that anterior is good and posterior is bad. And I would tell you that as a surgeon that knows how to do 4 out of the 5 approaches and teaches on them and fellowship trained on them, I'd tell you that all the approaches have their positives and all the approaches have their negatives. So if you look at sort of my preference, even though I'm trained in the anterior, teach on the anterior, have taught on the anterior, my preference is neither. My preference is the mini posterolateral. So it's a approach that's to the side of the hip, usually about a 3-inch incision, occasionally a 4-inch incision. It's muscle sparing, it's minimally invasive. The reason I like it is that it has the same recovery curve in terms of the fast recovery that you would expect from contemporary approaches, but it has far less blood loss and has a far less risk of fracture. So you get the benefit of recovering quickly without some of the headaches that patients can experience otherwise. What I would tell you as a patient, if you're thinking about hip replacement surgery, whether it's with me in this zip code or elsewhere, is the number one most important criteria is the surgeon. How many hip replacement surgery does he or she do in a year? And that's an important question to ask.
Yeah.
The second question to ask is the institution. How many hip replacement surgeries does the institution do per year? So the first question is important for the technique, the approach, the implant, the expected outcome and success. The second question is important for the process because there are a lot of hip and knees done, right? Today, for example, I did 6 hip and knee replacement surgery, and that's a very common day for most high volume hip and knee surgeons to do a good volume just because you're doing many of them and you're good at them. So those are the 2 most important questions to ask. And I'll tell you, very few patients ask me those questions. They'll ask me the other questions that are kind of out there.
Got it. And just another aside from that, you mentioned that the procedure that you like the most, are there indications in certain patients where you would need to do the other? And is that why you would do an anterior or a full posterior?
Yeah, so in patients who have bad deformities in their hip, let's say from a childhood injury, or like I saw a patient from Vietnam who he had this graft put in where he had a previous tumor, they'd excised his bone and they used his fibula and made that into his new thigh bone. And then 50 years later, that was when he was a kid, 50 years later, he's here and he has bone-on-bone arthritis, but big deformity. For that patient, that required a big posterior approach to open everything up and see everything well and reconstructed his hip in a way that was very complex and again very gratifying but very complex. The majority of patients who are getting primary routine hip replacement surgeries, we do in a minimally invasive fashion regularly, and for me, the large majority of my patients are same day. They're going home the same day.
Yeah, fantastic, great. You had mentioned it within the zip code, and the next question is from someone in Virginia who's watching from Virginia. Thank you for watching from Virginia. She says, how do I go about finding a doctor? So I think those 2 questions that you mentioned about how frequently the doctor does the surgeries and how frequently the clinic does the surgeries. Do you have any other hints or tips for people in finding surgeons?
Yeah, so I tell you, I see traveling patients, right? So many of the patients from Calgary, Canada will fly here, we'll do the same day surgery. They'll spend about a week here. They'll do the therapy here. Usually they'll stay at a hotel unless they have family or friends nearby. And then a day 8 or 9, they'll see me and then fly home. In the United States, we've treated patients from North and South Carolina, Florida, Alabama, Texas, kind of a whole bunch of places. Yeah. Most high volume hip surgeons end up doing televisits often. And you can get some opinions that way, whether you choose to make the trip to fly or not. It's not an unreasonable way to make sure that you're hearing what you might be hearing in your local area if you're not comfortable with that.
Great. Okay. Thank you. All right. You answered that question already. Can subchondral cysts contribute to hip pain, and are they treatable?
So subchondral cysts, it's a very, very good question. So subchondral cyst, the term cyst in our world is a really bad term that we use all too often, right? So when most of us think about cysts, we think about tumors or masses, and this is not that. A subchondral cyst is just basically an indicator that the bone, subchondral, so underneath the cartilage, the bone has gotten a little weak. And a cyst is something that we see on X-ray or an MRI as an indication of that. What a subchondral cyst means is that the hip arthritis has progressed now, where instead of being mild, you might be in the moderate category of hip osteoarthritis.
Got it. Okay, thank you. And is that also something that would be osteoporosis related?
No.
No.
So osteoporosis deals more with the bones. And so I can see why you asked that question, Karen. The cyst does not indicate any sort of positive or negative in relation to osteoporosis.
Okay, great. Thank you. All right. Let's see. So someone says, I'm 67. Often when sitting and when they move their leg in or out, they get a sharp hip flexor pain. Do you think, and this is one of those self-specific, could it be arthritis or muscular? I mean, obviously it could be either, but what are your thoughts on that? Just hearing that much.
Yeah, I tell you, if it's something that's affecting your quality of life, and I think sitting is one of the most common reasons patients come in to see me or somebody like me is because they're having issues with daily life things, right? So sitting, yep, sleeping, walking. And so if sitting is bothering you with simple movements like that, I think it makes sense to get an evaluation.
Great, thank you. Are there new treatments on the horizon for hip osteoarthritis, such as a cartilage replacement?
If the horizon is long, there may be, right? So if we're talking, 15, 20 years, maybe. All of the current data we have does not show that there's any cartilage regeneration capability for any of the things that are out there. So we look at stem cells, platelet-rich plasma, some of the nutritional things that are out. None of those things are regenerating any cartilage at the moment.
Got it. Okay, thank you. All right. If CAM deformities typically cause labral tears, are they ever work injury related?
So that's a dilemma and something that I see often in my office, right? So if we shell that out a bit, let's imagine a patient who is at work, has an injury, the labrum tears. Previous to that injury, the patient had no pain, was functional, doing everything, no issues. And then we find out they also have CAM impingement. So the issue there is that the CAM impingement is not work related. CAM impingement is something that they developed over the course of time. But the labrum tear, it occurred at work and they didn't have symptoms beforehand. So oftentimes the labrum tear can be work related.
Got it. Okay, thank you. All right, and I'm trying to do two things at a time. Listen to you and look at the next questions because they keep coming in. Is buckling of the thigh area often related to hip problems?
Yes.
Okay. If one has pain walking whenever putting weight on the leg, what kind of specialist should that person begin with?
It really depends on where the pain is. Oftentimes, as long as you see an orthopedic surgeon, then they will guide you down the right path. So if you have leg pain, and let's say that the leg pain is more focal to the knee, then you might see somebody like me, a hip and knee doc. Whereas if you end up having pain kind of in the ankle region, then you'll be put in the hands of a good foot and ankle specialist to be seen.
Great, good advice, thank you. Okay, can you explain what physically occurs to cause the catching or locking sensation in the hip area? And is there anything to solve that?
Yeah, so let's look at two scenarios. You have the labrum tear and you have arthritis. So if we start with arthritis, if you remember that diagram, that schematic that showed arthritis where the ball was cobblestone, right? It was kind of the little fractures in the cartilage. So it's not smooth anymore. So what's happening is as that ball moves, instead of being nice and smooth, right, that ball is ratcheting. So it's giving you that locking sensation. When you have a labrum tear, it's a different situation. The lining is nice and smooth, no issues. But the labrum can flip into the joint and get stuck, and it can give you that locking sensation. And then when you manipulate your leg, the labrum can move back out.
Got it. Okay, thank you. All right, and you kind of already mentioned this, but someone asks, do the muscles have to be cut for hip replacement?
No.
Yeah,
Now,
that's what you said earlier. So.
Yeah, and it's important to recognize that even if you go to a surgeon, and I want to be careful about this, because even if you go to a surgeon that does an approach that maybe isn't what's marketed or out there in the media, right? There are very, very good surgeons that I know that I would send family to get a good surgeon to do a large posterior approach, total hip replacement, because we know they're going to do a great job. And they're really good surgeons that I would send them to that would do a large anterior or a large lateral. So really, really, I would tell you again to make sure that you ask those first two questions, right? The surgeon question and the institution question.
Yeah, great. Okay, thank you. And then someone asks, with the posterior lateral approach, would the patient still have hip restrictions post-op?
No, so those videos and pictures I showed in the talk, those are all patients who've undergone a mini posterior lateral approach. They do not have precautions. The only time patients have precautions are if there's any reason for hip instability. So bad deformities, right, where we have to kind of take down muscle. People that have had previous hardware, previous fractures, things that are more complex, regardless of approach, those complex things usually end up having some restrictions for a period of time.
Got it. Okay, thank you. All right. Can you get a cartilage injection in the hip or only in the knees?
So I think you're referring to maybe viscosupplementation, which is the gel injections. And
Probably.
the gel injections are FDA approved for the knee. They're not approved for the hip. So people are getting them, but they're getting them off label.
Got it. Okay, thank you. All right. Is there a concern about hip dislocation after hip replacement? It sounds like no, but
there is. There's always a concern, right? So even in a native hip, meaning not a replaced hip,
right.
If I were to get into a bad car accident tomorrow, I could dislocate my hip. And similarly with a hip replacement, it's the same idea. With a prosthetic hip replacement, the concern is always there. The risk of it happening is about anywhere between 0.3 and 0.5%. So 0.3 to 0.5%. So it's pretty low.
Great. Okay. And let's see. How does a diagnosis of osteopenia or osteoporosis affect which procedure or which approach you choose?
Yeah, so if a patient has osteoporosis, then number one, just like all patients, we have to be careful in the operating room. But number two, if they're older with bad osteoporosis, it affects what we use, what type of implants we use, and how we may put them in. That's really what affects it the most.
And the type of surgery you'll do, it sounds like too, from what you were saying before. It depends on the person's health. It depends on the person's abilities. Okay.
That's right.
Great, thank you. All right. Someone who's 67 has had relief of hip pain from physical therapy. However, how long can I expect the benefit to continue? With osteoarthritis, will I eventually need a hip replacement?
So the downside of osteoarthritis is that it's a progressive disease. The upside of osteoarthritis is you don't know where in this curve you are.
Right.
So if you're here, you may do just fine for a really long time without needing anything. If you're here, it might be sooner than you would like.
Got it. Thank you. All right. Let's see. We've asked that. Is osteoporosis considered an orthopedic problem?
Osteoporosis is part of the orthopedic musculoskeletal world. However, most doctors that treat osteoporosis, whether it's with some of the bisphosphonate medications, some of the IV medications, or in other patients with mineralizations is used like vitamin D or calcium, most of the doctors that are treating them are not surgeons. They're usually rheumatologists or bone health specialists.
I think I could have answered that one because of all of the wonderful talks that IBJI has done. But that's what I thought you might say, but I judge myself on that. All right, last one that we have here, and then we'll stop because it just clicked on to 8 o'clock. Does a bone spur in the hip joint make a difference in which type of surgery is performed?
It does. So if it's an isolated bone spur with a labrum tear without significant osteoarthritis, that patient commonly, if they're going to get surgery, would get hip arthroscopic surgery to save their hip and repair their labrum and correct the impingement and clean up the bone spur. On the other hand, patients who have bone spurs, if they have significant arthritis, then when we do the hip replacement surgery or hip resurfacing surgery, then the bone spur is removed.
Yep, great. Got it. Wonderful. Dr. Shah, this was really informative, and I loved how you put things in lay terms for all of us. So thank you so much for your time tonight. Thank you so much for putting this together. Thank you everyone who joined us, and thanks for all the great questions, and thanks for answering all the questions. It's fun to get through every one of them. So thank you. If I missed any, my apologies. That's on me, not Dr. Shah. So
you're welcome. Thank you. Thank you for putting it together. It was great.
Absolutely. Have a great night. Thanks again.